Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening. As always, go check out reallifepharmacology.com. We got a free 31-page PDF on the top 200 drugs. Great study guide if you're taking pharmacology exams, board exams, great refresher if you're out in practice as a healthcare professional. So simply an email will get you access to that. Definitely go take advantage of for that at reallifepharmacology.com. All right, the drug of the day today is albuterol. I believe I have covered beta agonists a little bit in the past, but I wanted to get into some a little bit more specific detail with regards to the use of albuterol. So this is a beta agonist type medication. More specifically, its primary action is going to be at beta-2 receptors. Brand name of this medication, in practice I see Ventolin and probably ProAir used the most. There are a few other obscure names there as well. But that mechanism of action, acting as a beta-2 receptor agonist, is going to cause smooth muscle relaxation in the lungs. And that obviously helps people breathe better, breathe easier. Okay? So that's an important mechanism to remember. Now, I also want to mention that beta-1 receptors are very, very important in cardiovascular concerns. And if that dose of albuterol is aggressive, we can start to lose selectivity a little bit. So that's an important thing to remember, and that's going to play into the adverse effect profile, which I'll discuss coming up here. But thinking about the more aggressive the dosing, generally the less selective a medication is going to get. Now, in using albuterol through inhaler, through nebulization, we usually don't tend to get too much of those systemic adverse effects, but this can vary based upon patient variability. So it's important to definitely remember that with regards to albuterol. The more you use it, more frequently a patient uses it, the more and more likely we're probably going to run into some of those beta-1 agonist adverse effects that I'll discuss. So understanding that this opens up the airway, primary uses I see this medication used for is asthma, exercise-induced bronchospasm, COPD. So those respiratory type conditions. And I always pretty much see the albuterol inhaler and nebulization used versus systemic type therapy. So there is oral formulations as well as oral syrup formulations. And when we give it systemically or through the GI tract, we get more intolerances, basically, more adverse effects, more systemic side effects. One other potential use for albuterol is hyperkalemia, so elevated potassium levels. So it's not frequently used for this indication, but it can be considered kind of as a last line or an add-on type therapy in patients that aren't responding to serious elevations in potassium levels that cause EKG changes and things like that. So again, usually in emergency type situations with elevated potassium, we're using calcium and insulin with glucose to get that potassium level down. And then, dialysis is always an option or consideration as well, depending upon the response to traditional therapy. And then kind of down that list as well is albuterol. So mechanistically, similar to insulin, the beta-2 adrenergic agonists, like albuterol, drive potassium into the cells. Okay, so that's how it helps in treating hyperkalemia, as it drives that potassium back into the cells, which ultimately lowers serum potassium levels. Dosing and dosage forms, I alluded to what we've got available. Meter dose inhaler, nebulized formulation, oral tablets, oral syrup. Again, we don't use those oral options very often because of the potential for increased systemic absorption, obviously, and systemic adverse effects. For the meter dose inhaler, it's 90 micrograms per actuation. Typically, most kind of standard orders are 1 to 2 puffs every 4 to 6 hours as needed. And then the nebulized solution, this is given over 5 to 15 minutes. So that nebulizer is going to be used in patients that have trouble utilizing an inhaler, whether it be, coordinating the movements or whether it be being able to manipulate the device, the patient being able to manipulate the device on their own as well. So young and old is typically the way I remember who's probably going to benefit most from nebulizers. It's kind of a big general overview, but there's obviously some exceptions to that. Those that have cognitive problems or things of that nature where meter dose inhaler just isn't the right fit for them. So think about that. And whenever you see a non-responder, like somebody that's not getting relief from their inhaler, that's always a good time to double check their technique, making sure that's appropriate, and assessing if we should use a nebulizer instead. Adverse effect profile, let's get into that a little bit. It kind of ramps you up, or it can ramp you up. The more albuterol we use, the more likely you're going to see some of these things. So tachycardia, an elevation in heart rate, can get shakiness or a tremor type sensation in some patients. Hypertension, insomnia. So again, can kind of amp you up a little bit as that dose escalates, or if you've got a patient maybe that's a little bit more sensitive to the adverse effects there. The one other one I'll mention is hypokalemia. So dropping that potassium level too far. Again, probably not going to see that issue in patients that, use an albuterol inhaler as needed, once or twice a day. Those potassium fluctuations probably aren't going to be significant enough. But if you've got patients, at risk for hypokalemia, maybe they're on other medications like, thiazides, loop diuretics, for example, that may be something you watch a little bit closer, particularly if they're using their albuterol inhaler a lot. Contraindications, precautions. So, paying attention to cardiovascular disorders. So if, patients have, uncontrolled hypertension, for example, if they've got a history of significant arrhythmias and tachycardia, that albuterol certainly could make that worse. Now, we've always got to weigh that with the risk versus benefit of, okay, this person's having trouble breathing, like we need to give them albuterol because that's the priority at this time. So that's always, kind of that risk versus benefit in weighing that clinically. Again, the potassium levels, just paying attention to that. If you get somebody that's really susceptible to low potassium levels, that albuterol could dip that a little bit further. Monitoring parameters, really we're looking for response in respiratory symptoms for its primary use. That's what we're going to be looking out for. And then, you could monitor heart rate, those type of things if we're concerned, blood pressure, if we're concerned that it's going to exacerbate that a little bit. But generally, we don't monitor labs too closely, unless maybe you've got somebody with excessive use or something and, checking potassium levels, for instance. Couple points, or 1 point for sure on pharmacokinetics. From an oral standpoint, it is virtually completely absorbed when we give it oral tablet or syrup, so it's got good systemic absorption there. So again, that's why we really don't want to use it there, because we just want to affect the lungs. So the nebulization and the inhalers, generally it's going to be less than 20% absorption, 20% or less absorption systemically. But again, the more you use it, that increases the dose, and, if that percentage of absorption stays the same, obviously you're going to get a higher dose as you use that medication more and more. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, BCMTMS, or the NAPLEX exam, go check out meded101.com/store. We've got a growing list of resources. We've helped thousands of pharmacists pass their board exam, and we can absolutely help you too. So again, go check out meded101.com/store. If you're looking for other resources on drug-food interactions, clinical case studies, pharmacotherapy pearls, go check out meded101.com/store. Got links to books on Amazon, all sorts of different stuff for pharmacy technicians, nursing healthcare professionals, med students, PA students, NP students, anyone needing pharmacology education. So again, all those links, meded101.com/store. All right, wrapping up with drug interactions. So first and foremost, beta blockers. So we've got albuterol, which is a beta agonist, and we've got beta blockers, which is going to directly oppose the action of albuterol, or potentially. You can get into the weeds a little bit here. So, beta blockers also have certain selectivities. So a beta blocker like metoprolol tends to mostly block beta-1 receptors. So that beta blocker isn't going to impact the respiratory function quite as much as a non-selective beta blocker like propranolol. Okay, so that's an important distinction to remember. I will say this is all dose dependent. Obviously, the higher you go on the dose of metoprolol, the more and more likely that you're going to potentially blunt or block the beta-2 receptors as well. So again, that selectivity is dose dependent. The higher the dose you go, the more and more likely you're going to block both receptors to some capacity. Okay, so again, classic example, metoprolol, beta-1 blocking agent primarily. Propranolol is a great example of a non-selective beta blocker and would probably likely have more impacts on negative impacts on respiratory function. So again, beta blockers can directly oppose the efficacy of albuterol. Some are worse than others, like propranolol. All right, next class of medication, I guess, would be stimulants, and this is obviously a big, broad category, but we've got ADHD medications like methylphenidate, for example, brand names of Adderall and Ritalin. We've got pseudoephedrine, which can have some of that type activity as well, where we can increase the risk for tachycardia as well as potentially hypertension. We've got medications, which I guess maybe is not considered a medication, maybe more of a dietary supplement, dietary food intake, and that's caffeine certainly. So that can contribute to some tachycardia, insomnia, maybe some shakiness, some tremor type sensation. So all these drugs can have additive effects on top of albuterol, and this is definitely something that I have looked out for in practice. I've seen this as part of the prescribing cascade, where patients get diagnosed with tremor or essential tremor, and then they get put on a tremor-relieving medication, such as primidone, for example. And you go back and you look at the medication list, and it's like, well, they're on 2 or 3 stimulants, and they're taking a bunch of albuterol. That's a great example of the prescribing cascade, and hopefully we can do some things to potentially reduce those medications that are, causing or contributing to those tremor type of symptoms. Another drug interaction to think about, I alluded to this one before, I believe, diuretics. So loop and thiazide diuretics, These can cause significant drops in potassium levels or hypokalemia, and albuterol may enhance that or exacerbate that potassium lowering effect, and we can make it go too low, which obviously isn't good. A couple other things to think about involve cardiovascular concerns. So there is some evidence out there potentially QT prolonging agents in combination with beta agonists like albuterol, it could potentially exacerbate that effect. I've done a bunch of stuff on the blog on MedEd 101 and QT prolongation. So if you just Google search QT prolongation, MedEd 101, there's lots of good information on that particular adverse effect and drug interactions as well. So go check that out if you're looking for more detail there. And then the last one I will mention are tricyclic antidepressants. Great example is amitriptyline, nortriptyline. There is potential that cardiovascular toxicity, cardiovascular effects could be exacerbated by the use of a beta agonist like albuterol. Again, not something I probably come across terribly often because most patients, again, are just going to use albuterol periodically or hopefully. I mean, we don't want them leaning on their albuterol inhaler chronically, 3, 5, 8 times a day. That's not good for our patients. We need to make sure their respiratory status has better control. But in the event that you do get that patient that's using it quite a bit, tricyclic antidepressants could potentially add to some cardiovascular risks in combination with albuterol. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, do me a huge favor. Leave a rating or review on iTunes or whatever platform you're listening on. I greatly appreciate that. It helps us grow the audience. Share us, friends, colleagues, anybody who could benefit from pharmacology education. Appreciate that as well. If you got comments, questions, suggestions, looking to sponsor the podcast, certainly feel free to reach out to me, mededucation101@gmail.com, or you can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care and have a great rest of your day.